Dear students, this is Dr. Dahbour. Today I'm going to talk about headaches. As you know, your reference book is Lecture Notes on Neurology by Lionel Ginsberg, and it has a chapter about headaches. I think it's chapter 10 named Headaches and Facial Pains. I think this is a very well written chapter and it's self explanatory and straightforward. So please review that chapter and look at it. And then you look at and listen to this lecture. This is my own collection, and I will just go over an overview of this common important subject. So headaches. Why to bother about headaches? Actually, if you think about it, every one of us must have a headache at least one time in his life. You cannot survive for the age of 40 without having a headache at least once. But those people who complain about headache and they don't necessarily complain about it to a doctor, they complain it to somebody else. For example, a man talks to his wife that he has headache, or the other way around, or somebody talks to his friend. Almost 40–50% of patients of people will complain about headache. So if headache is so common, so ubiquitous, this means that the overwhelming majority of headaches are benign. So why to bother about headache? The main reason to bother about headache, we really want to rule out serious neurological disease. That's what it is. So people, when they have headache, they are afraid that there is something wrong inside their head. So we need to rule out serious neurological disorders. And that's by doing a proper or making a proper diagnosis through proper history and physical examination and appropriate investigation. So the first aim is to make a diagnosis of headache. The second aim is to treat the pain relief, because pain is not something good. Now I'm talking to you, I have some pain in my neck, and really I will do anything to relieve that pain. Pain is a very bad experience, so you have to relieve the headache. So we talk about headaches, we talk about acute versus chronic headaches. By the way, headache means pain in the head, and head by definition here includes the area above the neck excluding the face. So the pain in the face is called facial pain. So headache will be the pain in the head excluding the area in the face. So facial pain has other differential diagnosis in general. So we are interested to differentiate whether this is an acute headache, and this acute headache could be a headache that occurred over minutes, hours, or days, or it can be acute in a sense that somebody used to have a headache, but now it has changed from its known character. So this is a new headache on top of a chronic headache. And if it was a chronic headache, we would like to know whether it is stable, it's the same type of headache that the patient used to have, or whether this headache has changed and better. So when we talk about acute headache, we are interested to know whether it is associated with systemic symptoms like fever, rash, flu symptoms, upper respiratory tract infection, and so on and so forth, or associated with neurological symptoms like change in the level of consciousness, seizure, weakness, or any other neurological manifestation. So when we assist a patient with acute headache, so we do after we take the history, we do the general examination, looking at the patient, whether he looks ill or not, and we do his vital signs. We examine the skin and we do a systemic examination of the different organs. Then we do a quick organized neurological examination, and that should include a fundoscopic examination as well as meningeal irritation signs. So there are different causes of acute headaches. So this could be traumatic headache, post-traumatic headache, or non-traumatic headache where you have no history of trauma. The traumatic headache, whether this is related to simple closed head injury or complex injury complicated by subdural, epidural, hematoma, or subarachnoid, or intracerebral hemorrhages. The different causes of non-traumatic headaches include the primary headaches like the migraine, the cluster headache, and the tension type headache. There are the vascular headaches, including the subarachnoid hemorrhage, the primary intracerebral hemorrhage, sinus thrombosis, dissection, vasculitis, ischemic stroke, CNS infection like meningitis, meningoencephalitis, abscess. Then you have non-vascular intracranial diseases like intermittent hydrocephalus, idiopathic intracranial hypertension, intracranial hypotension, tumors. If something acute happens in these tumors like degeneration or bleeding, pituitary apoplexy, Arnold Chiari malformation where changes in the pressure occurs acutely, certain metabolic disorders like pheochromocytoma with surges in blood pressure, certain drugs like nitrites, which are known vasodilators that would lead to gush of blood inside the cranium, leading to this throbbing headache, withdrawal syndromes if somebody is used to a certain drug, and patients with COPD, for example, with hypercapnia, when their CO2 goes quite high, this is associated with vascular dilatation and increased intracranial blood flow. Again, you have other causes: hypertensive encephalopathy, cervical spine disease, dental diseases, ENT diseases, ophthalmic diseases, or secondary to general diseases. So when we diagnose serious headaches, including brain tumors, these are some of the clinical tips that will help you to think that you are dealing with a serious headache. So if it is an acute, recent onset headache, usually severe headache, and you have to pay attention to these. Headache that has changed from prior types of headaches, headache that comes in exertion that in general reflects increased intracranial pressure, progressive headaches, the headaches that is getting worse over time, and headaches that are associated with fever or systemic symptoms. You have to make sure that you're not dealing with a CNS infection. Any patient with meningeal signs, and any headache that is precipitated with Valsalva maneuver, again, indirectly indicating increased intracranial pressure, or patients has headache and any neurological sign, or patient if the headache starts above the age of 50, or headaches in children in general. All these are considered red flags whereby you have to be a little bit cautious and to do proper history and physical examination. So how we assess these patients after the history and physical examination? By doing imaging studies like brain CT scan, and sometimes we resort by doing a CSF study. Also, so that's we differentiate headache between acute and chronic, and again here we differentiate between headaches excuse me, primary versus secondary. So primary headaches where the headache itself is the issue, and there is no clear cause, either systemic or neurologic cause for this headache. And the secondary headache is the headache that is part of a systemic disease, where the headache is considered part of a general neurologic or systemic syndromes. So these are the primary headaches, and these are the secondary headaches. The primary headaches, the most common type of primary headache is the typical tension type headache, which constitute around 70% of headaches. This is a typical mild to moderate headache that is diffuse. It's a band-like, non-throbbing headache. not associated with autonomic symptoms, and that's lasting from hours to up to 7 days. And typically we can work through this headache, and this is the most common type of headache and the most common cause also of what we call daily headache. So people who gets almost daily headache, or by definition they have headaches 15 days a month, these are called chronic daily headaches. So tension type headache is the most important. The second type of primary headache, more or the less second common, is the migraine. Migraine or يعني صداع الشقيقة. Migraine is quite common. It's maybe quite disabling disease. It's one of the most common cause of absence from school or work. And you can think that at least when it comes to ladies, 20% of ladies, they have migraine, and in men, 10% of men, they have migraine. And so in the general population, around 15% of the general population, they have migraine. And we are talking about the adult population, typically starts in the teenager. There are two types of migraine: the migraine with aura and the migraine without aura. And the migraine with aura used to be called the classical migraine, which is the minority. So around 10% of migraine are migraine with aura. And the migraine without aura, or the common migraine, which accounts for 90% of migraine. So the clinical presentation is the same, except that the aura is present on migraine with aura, which typically precedes the headache, lasts for around 4 minutes to 60 minutes. And typically it's either a visual aura, where patients will see certain lights in his visual field, or something like fireworks, or he sees scotomas in one of his visual fields. And that is typically within 60 minutes of this aura, the patient suffers from the headache. The headache typically is unilateral, and it is throbbing, and it is moderately severe to severe, and it lasts between 4 hours and 72 hours. It is associated with nausea and vomiting, and can be associated with photophobia, phonophobia, and osmophobia. When you see the patient in the acute attack, they look in severe pain, and they have what we call scalp allodynia. So if you touch their scalp, they are tender. So this is the classical migraine and the migraine without aura. And migraine with aura, except that the patients, they have the aura, as I mentioned. The other important type of headache is the cluster headache. The cluster headache is more typically found in men than in women. It awakens patients from sleep. It's very severe. It's typically orbital or periorbital. A patient feels as if his eye globe is going to get out of his eye. Typically awakens patient from sleep, and it comes in clusters. These clusters, they last between 4 and 8 weeks, meaning that they come almost on a daily basis for this period, and then they disappear for a few months to 1 or 2 years, then they come back again. So that's why they call it cluster headache. It lasts between 20-30 minutes and 180 minutes, and it is very severe. It's associated with significant autonomic features, especially tearing, ptosis, like Horner syndrome, and runny nose, and the patients become quite irritable because of this headache. So you diagnose this based on history. It's quite relatively rare compared to tension type headache and migraine. Other types of headache, like stabbing headache, exertional headaches, these are again, we don't see them except rarely. The secondary headaches, the most common cause of secondary headaches is infection. So patients who have especially upper respiratory tract infection like flu, sinusitis, tonsillitis, all right, meningitis. All these patients, they are associated. So 2/3 of secondary headaches are related to infection, including, of course, CNS infections. Then you have head trauma. Then you also have vascular headaches. And as you see, tumors as the cause of secondary headaches is rare compared to other more common causes like the infection and the trauma. So these are certain tables. I would like you to look at them. There are certain definitions of common types of headache like migraine with aura, migraine without aura, episodic tension type headache, and the chronic tension type headache. And then we come to the chronic daily headache is the headache that is associated, occurs on almost on a daily basis, and by definition, at least 15 days per month. And that can be caused by different disorders. The most important one is transformed migraine, meaning that these people have history of migraine in the past, and then now their headache changed from infrequent typical migraine attacks to frequent type of headaches that comes almost on a daily basis. And the clue for that, if you take a proper history, you will find that the patient has typical history of migraine in the past, or patients who abuse medications. They start with certain either headache or other pain, and they start taking medication, pain medication, on almost daily basis, and that will lead to a form of persistent headache, daily headache. And you can diagnose this based by exclusion and by taking history that these patients are taking medications for the last 3 months almost on a daily basis. And there are different definitions. Depends, for example, if talking about orgotamine, talking about 10 days per month, and if you take simple analgesic, 15 days per month. And the treatment of these people is to try to withdraw these medications and to bridge them with, for example, an antidepressant, or sometimes we use steroids. So just look at these tables. And again, here, you don't know to remember these, just for general information about these types of headaches. Now, when we come to imaging, as you see, most of patients with headache, they do not need, if you take proper history, they do not need imaging. So if a patient comes with a typical tension type headache, normal examination, normal fundoscopic examination, normal blood pressure, or a patient comes with a typical migraine story or cluster headache, these patients in general, you can manage them without doing neuroimaging. And this is a series of patients where they looked how much patients with typical stories, they have abnormal imaging, brain CT scan or MRI. And as you see in migraine, studying almost 1,100 patients, 2 per 1,000, I mean, they had abnormal images, and these abnormalities typically are benign. And then the tension type headache, studying 83 patients, there were 0. And patients who have chronic headaches for years and years, typically they have, again, very low yield. So we just use images for patients who have either acute headaches that you cannot explain by one of the primary headaches, or a patient who has a headache associated with either systemic or neurologic other manifestations. Regarding treatment, in general, tension type headaches are treated by reassurance and by using simple analgesia, and sometimes we use antidepressant. For migraine and cluster headaches, there are 2 kinds of treatments. For migraine, there is what we call abortive treatment, where you treat the attack itself by using either simple medication like non-steroidal or aspirin or even paracetamol, or using more specific drugs like using triptans. And then we go for the other type of treatment, which is the prophylactic treatment. We use this prophylactic treatment for patients who either have severe attacks or have frequent attacks. So the commonly used drugs for prophylaxis include the beta blockers, the anticonvulsants like the topiramate, like the again the valproic acid, and the antidepressants like tricyclic antidepressants. Again, we use also sometimes calcium channel blockers. Sometimes in acute attack or called status migrainosus, we can use a short course of corticosteroids. Again, in chronic migraine, now they are talking about using botulinum toxin for those patients who did not respond to other medications. There are also sometimes certain devices that are used, though these devices are licensed, but there is no class 1 evidence to suggest they are effective. For patients with cluster headache, we use as an acute treatment, we use high flow oxygen, we use sometimes short course of corticosteroids, and for prophylaxis, we use calcium channel blocker. The best one is verapamil, and we can use also topiramate for that reason. Now I will show you a few cases about headache. So this is a patient with headache, fever, and rash. So as we said, if you have a patient with evidence to suggest a systemic illness, so this is a classical patient with meningococcal meningitis. So you see this rash, and you see even subconjunctival hemorrhage, and this patient was quite sick. So this is meningococcal meningitis. You prove that by doing of course, an LB as far as you don't have a contraindication for it. And now this is a 70-year-old man who had his worst headache in his life. So sudden severe headache in somebody who is in his sixth or seventh decade who presents with this headache. Sometimes these patients, the only manifestation is they just headache. So this is a classical scenario for someone who has a subarachnoid hemorrhage. And as you see here, this is the clot here. It's in the anterior communicating artery, and you see the aneurysm here. And this is in the formatted angiogram. So this is a classical aneurysmal subarachnoid hemorrhage. And here we have a patient with sudden headache and right-sided weakness with history of hypertension. So if you have somebody with headache and focal neurological deficit and his blood pressure is high, so this patient presenting with a stroke syndrome, and because of the high blood pressure, because of the headache, you have a high chance in this patient has a hemorrhage, and that's true. So this patient has a basal ganglia hemorrhage, which is one of the most common sites for parenchymal hypertensive intracerebral hemorrhage. So these patients present with an acute headache. This is a young lady with use of oral contraceptive pills to prevent pregnancy, and she presents with severe headache. All right, so a patient, a young lady who presents with severe headache, and you take a history if she is using oral contraceptive pills or if she has history to suggest a thrombophilia. And when you examine her, this lady, typically they have papilledema, then you will appreciate that this lady most probably has sinus thrombosis. And when we do this image, we will see that the inferior sagittal sinus is thrombosed. So this is sinus thrombosis, one of the causes of what we call thunderclap headaches, all right, severe headaches. Again, this is a real patient with post-cardiac catheterization. He had developed headache, dizziness, vomiting, blurred vision. On examination, he has a left visual field defect. So this patient has Of course, from this scenario, this is an embolic stroke leading to right temporal lobe infarction. All right, so this is, again, these embolic strokes, sometimes they may present with headaches. And this is the same patient that he developed another headache later on. So now he developed the bleeding inside the infarct that he had before. So this is a hemorrhagic transformation of an occipital lobe hemorrhage, occipital lobe infarction. This is a patient, a lady who presents with headache that is over the weeks and months is getting worse and worse and worse. So this is a progressive headache, and this is an imaging of sphenoidal wing meningioma, very classical meningioma, all right? This lesion that is diffusely enhancing. So this patient will be relieved once you get out this meningioma. This is a patient who had headache that was persistent after a lumbar puncture. And you see there is a diffuse meningeal enhancement as shown by these arrows. So this patient, every time he stands up, he develops headache and nausea. If he lies down, he feels better. This MRI shows diffuse meningeal enhancement consistent with intracranial hypotension. So intracranial hypotension is again of causes of acute headaches. And the treatment of this patient is to supplement them with fluid bed rest, and sometimes we use aminophylline to treat. We have treated few patients based on a paper published recently, and they do very well on aminophylline. So this is intracranial hypotension. So this is a young obese lady with diffuse headache, increased upon coughing, and with diplopia, double vision. When you examine her, you see that she has a sixth nerve palsy and she has bilateral papilledema. So if a lady comes that is obese in the childbearing age with diffuse headache that is consistent with increased intracranial pressure, so this headache is more in the morning, increases with coughing, straining, and is relieved during the day, may be associated with double vision. And when you see papilledema, so this indicates an intracranial hypertension. The first thing you do, you have to make sure that you don't have a space occupying lesion. So once you do an imaging and the no space occupying lesion is there, the next step we do an MRV and to exclude sinus thrombosis, as in the case that I showed you before. If this is negative, then most probably you are dealing with idiopathic intracranial hypertension. So here we do a lumbar puncture. You do the lumbar puncture and you will see the criteria that is consistent with increased intracranial, idiopathic intracranial hypertension. So the CSF will be clear and colorless, and the pressure will be quite high. Typically, the normal pressure from 10 to 20 centimeter of water, you will find it to be more than 30, more than 40, sometimes 50, 60, 70s, and so on and so forth. And when you send this CSF for analysis, it's basically normal. There is nothing abnormal in it, normal cells, normal protein, normal sugar. So these are the defining criteria for a patient with idiopathic intracranial hypertension. This is unfortunately a common syndrome. You will see patients when you do your clinical rotation in neurology, and these patients are treated by, first they have to reduce their weight, and number two, we treat them by using acetazolamide to reduce the production of the CSF. And if these do not work, we may consider things like optic nerve sheath fenestration or theco lumbar shunt. So we do, our neurosurgeons will put a surgeon from the thecal sac in the lumbar area to the peritoneum. Okay, so this is the most feared complication for these patients is that they lose their vision. Of course, you look for other secondary causes like hypothyroidism or steroid related or related to certain drug abuse and so on and so forth. So this is idiopathic intracranial hypertension. You have a good description about this on your book. All right, so this is idiopathic intracranial hypertension with papilledema. These are the diagnostic criteria which I just went over now. Just look at these criteria. This is an elderly man with headache and deterioration is his vision. The fundoscopic examination shows an ischemic optic neuropathy. So any elderly patient who presents with headache and some blurring of vision, or even without blurring of vision, any elderly patient, even any patient above the age of 55 who presents with headache that is more focal on one of the temporal areas, all right, and that is severe. And when you examine them, you will see that their temporal arteries are not pulsatile and they are tender. Think of temporal arteritis. And the simple test to support your diagnosis is to do the ESR. Typically, the ESR is quite high. You find it in the 80s or above 100. So this is a classical scenario of a patient with giant cell arteritis. You ask these patients about jaw claudication. So when they eat, whether they have pain in their jaws. Sometimes they have polymyalgia rheumatica. They have aches and pains in their shoulders. And if that's the case, then you have to suspect giant cell arteritis. You have to treat these people as quickly as possible with high dose corticosteroids and to arrange for a temporal artery biopsy, whereby it will show the typical non-caseating granulomas consistent with giant cell arteritis. So this is a giant cell arteritis in this patient with an ESR of 100 and optic disc pallor. Thank you very much. So this is an overview of headaches. Please review the chapter in Ginsberg. I think it's very well written and it's very clear. Also talk about facial pain. The most important cause of facial pain is trigeminal neuralgia. Trigeminal neuralgia is tic douloureux, where patients, typically a lady in her fifth or sixth decade, they complain of lancinating pain that is around the eye and in the distribution of either the ophthalmic or maxillary branch of the trigeminal nerve. These are short-lasting and severe and very annoying, and they are typically associated with certain maneuvers. There are certain trigger points that they come to the that they initiate this attack. So patient when smiles, when he chews, when he talks, he has these episodes, and sometimes this is so annoying. The patients really they cry because of that. They typically I always refer them to a dentist first to make sure that they do not have a dental issue. If the dentists say that they are okay, there is no problem with them, because a lot of secondary trigeminal neuralgia are related to dental diseases, dental issues. So what we do after that, we do an angiogram, an MRA, looking for any vascular compression of the trigeminal nerve. If there is nothing, then we consider this to be idiopathic, and we treat these patients typically with carbamazepine, which is the best drug to treat these patients. So again, look into this. This is a relatively common. If it occurs in younger patients, if it occurs, for example, in somebody who is 25 or 30 years old, then you have to think of secondary causes of trigeminal neuralgia that may indicate either a tumor compressing the trigeminal nerve, or, for example, an MS black that is touching the origin of the trigeminal nerve. So, and in young people, they have really to be investigated more thoroughly. Thank you very much and have a good day.